Good afternoon. Thank you so much for joining us at the Voices podcast. My name is Arafat. Today in the studio, we are joined by Professor Nkusi Agabe, Emi. He's a renowned neurosurgeon and he has done a lot of things to ensure that Rwanda's health sector progresses from one step to another. And today, we have him here to discuss on ATLS, Advanced Trauma Life Support chapter, that was recently launched in Rwanda to really get a deeper understanding of what it is and why we have it here today. Professor, thank you so much for joining us.
Hi, Arafat.
Hi, how are you?
Good.
Are you doing well?
I'm good, thanks. How are you doing?
I'm really fine. I'm trying my best and everything is well.
Yeah, it's good to keep well.
Actually, I don't know, but I wanted to ask you, how is life? You know, as your doctor, you people, we tend not to bother about you as if you're not. Do you get so many questions about how are you doing and how is life?
Not from patients, though.
Mm-hmm.
Because when they come,
I'm wondering.
they're only worried about themselves. So how do you expect them to start worrying about the ones that are going to seek help from? Because, when you go to see a doctor, you expect that doctor to be healthy, to be in control of everything.
But is it true? Because
definitely it's not. It's not true. Because sometimes the guy didn't sleep at night, he was operating the whole night, or he has a problem at home because we've got families as well. So, assuming that we are superhuman is not right, but the patient-doctor relationship makes it in such a way that the patient is going to come thinking that you in control of everything about life. So that's why we are never asked, Doctor, how are you? How is your life?
Oh.
Yeah, because it might change. Maybe the patient who will ask you that question, you may turn around and say, no, I'm bad, Prof. I have a headache, but he came for a headache, so who's going to help the other?
Okay. Is that the logic? Because I don't really understand
I'm not
that.
sure that anybody thought about it like that. But the assumption is that the patient coming to see you as a doctor thinks that you're in control
of everything
about life.
And even your life. They assume that you are healthy. You are...
Because some people actually ask when they tell them that the doctor is off sick. They say, doctors also fall sick. But you wonder why the doctors haven't multiplied, because we train every year. Some people are graduating as doctors and we don't see many. Because they die like the other people die.
But we really don't give much time to ask our doctors. I find it very disturbing because I think you also deserve that care. Come on. How do you feel if it has happened to you?
Outside.
Maybe if it has happened to you once. How did you feel anything? Because have you received anyone who has said, doctor, please, how are you doing? Before you even treat me, how are you doing? No. If it's not someone that you know, or maybe your relative, he's just passing by to say.
No, you can't. Because as I told you, I think the assumption is that the person is coming to get remedy from you, and therefore you are in control of life. Yeah, so they cannot start asking you how is your life, and they take. No, they've come with a problem. So they want it solved. Those who know you, and they have less pressing issues, then you can discuss if you are friends and
you know each other.
They're going to ask you about family and.
But doctor, you are very serious when you are in that chair. When you're in that consultation chair, you are very, very serious. You don't really easily attract someone to ask. You are too focused on what you're going to do after. What has brought you here? What has brought you here? And then how can I help you?
You focused on patients. It's a professional way of doing things. Because basically somebody is coming to tell you problems that you need to focus and see how you can solve them. So that's why the doctors are focused. They want to listen attentively, to be attentive. they get, a big chunk of what you're going to, how you're going to diagnose, how you are going to, person who's brought a problem to you, a big chunk of it is going to be gotten from the history. So that's why we focus a lot. So what a person tells you, you ask them questions, they reply. So by the end of the discussion, before you even examine, you already know the direction of where the problem is. So by the time you're examining, you're confirming what you had gotten as in the history, or you're excluding that. So that's how we do. You start thinking, so I think I should focus more on this, just from the discussion you've had. So then you start narrowing. By the end of the history taking, or that talk, the discussion you're having, before you even go to examine, you already have more than 60%.
I mean,
so you examine, now you confirm, or say, okay, so in this direction, then you go to examine to investigate, like the labs, or the x-rays, or the CT scan, the MRIs. Those are going to add a little.
Can't the history take you off the road? Because I mean, there's some people who are not good at telling the history of their disease. I mean, where it has started and where it is now. I mean, can't the history take you off the reality?
Yes, sure, it can. The only problem is that you have to also be, of course we learn that. The question you ask is like to bring the person. So, because sometimes you wait for them to tell you, and then you reach a level where you now start asking questions that are related to what you think is the problem, or the complaint the person brought to you. Now you start asking questions related to that complaint. So if you forgot to tell you something, then you ask them those questions related to that, to bring them back to, unless the intention of hiding it from you.
Oh, okay. So simply there's some patients who come with the intention of hiding the problem.
Well, we're not going to discuss that.
Okay. Now let's go to our question of today. So we want to talk about advanced trauma life support. I mean, can you explain to us, I mean, what does it mean, and why did Rwanda launch this? Why is it necessary?
Okay, so advanced trauma life support is, as you can hear, is advanced. So that means there's a systematic way of managing traumatic, the road accidents, fall from height. So trauma, physical trauma, that's what we're discussing, not the psychological trauma.
Yeah, of course.
Yeah. So it's an organized or systematic way.
But can you simply differentiate between this trauma we are talking about and the trauma, the psychological trauma? Yeah,
so that's why I'm saying physical.
It has to be a physical trauma. This is a physical trauma we're talking about. Yeah. Okay.
So physical trauma, you are foreign, you've been knocked by a car, you're involved in a car accident, you fell from height from a building, or fell in a ditch, a mine has collapsed on you. Those are the traumas we're talking about. Yeah. So why is it called advanced? Because you have other ones. We have basic ones that we teach people, like people who are cleaning hospitals, or people on the road in the community, how they can help. So those are basic ones. Now the advanced one has a background. Basically, it started by an orthopedic surgeon, American orthopedic surgeon, who was in his plane with his family. And he fell, there was a plane crash, his plane crashed in a farm field. He was called James, some other name that I don't have to say. So when they picked him and took him to hospital, the care he got with his family, unfortunately his wife demised. So him and his children were taken to a rural hospital, and the care they got was appalling to him. So he stated that if every day I give care to people that come to me, and what I've gotten, my children and I, what we've gotten is so appalling, is so low. It means the system is bad and it must change.
So for him, he hoped that anywhere in that country he would have got
So that
the
he
service.
he used to think that things are okay.
That the things he does where he works is the same thing happening everywhere.
Yeah. So until he got so bad, poor service, then he clearly stated that if my children and I have gotten this very poor service, then things are bad and they must change.
Sure.
So when he stated that, the following year, the American College of Surgeons, that was about 1978, yeah? So he was a surgeon. As I said, he was an orthopedic surgeon. So him and his friends, they set out to work on improving trauma care in the US. So they started small in their field, in the area, and by 79, they actually had it in the whole meeting of America, the American College of Surgeons General Meeting, and that's how ATLS started. So it's been a while.
It's been a while.
Yeah, it's been a while.
Why did it take long to be here?
Yeah, so it's a couple of things. For example, it requires the level of organization that is required is high. It requires that the system, as I said, it's systematic. So it requires that the health system is also improves. In other words, what is going to be used in helping those patients, and the conscious of the service providers need also to know that actually they need to change. We'll talk about it why this time in Rwanda. Yeah, but so there is that. As he was informed by his accident and not getting good service, the same happens in other parts of the world. Yeah, so it's not in every country because, like, for example, in Africa, so far I think we are the sixth country that's getting this chapter.
So, I mean, today as we speak in Rwanda, we have a lot of the trauma cases usually we have mainly from road accidents. And I think mines falling on people, workers also is part of that, I think.
Yeah, they're falling from heights.
And falling from heights. How will trained professionals in this field going to solve this problem? I mean, how are you planning to do it?
Okay, so as I said, it is a systematic way of managing a trauma patient. And for the listeners, you can only make a change in the outcome in the first hour of a person's injury. Yeah. So that's why we call it golden hour.
Golden hour.
Yeah. So the golden hour, that's the target of this ATLS. So the purpose of starting this chapter is because the health system in Rwanda or the government of Rwanda is trying to minimize losses
in the golden hour.
Losses
that period
losing life in the golden hour. Also, when life is not lost, the disability that comes from those injuries is lifelong, and we lose a lot of man-hour or capacity of people to work, to go back to the original work, because they were not handled properly in the first instance. So all that is what the Ministry of Health is trying to do. is trying to make sure that whoever gets injured gets access to care in the first hour, so that the injuries are handled appropriately in the first hour, so that the outcome also reducing death. You reduce death by 45%, by the way. The studies show that. And the disabilities also are reduced significantly.
I mean, when you talk about seriously the golden hour, doctor, let's be fair here. Let's say I've had an accident in Karonj, somewhere deep in the village. 1 hour for me to be at a modern hospital, maybe let's say advanced maybe at an advanced health center, I might take an hour before I reach there. Are you saying that these trainings are going to be given to people down on ground? Or are you going to do, because the golden hour some people take an hour before they reach hospitals?
Okay, so we've done actually a couple of studies in Rwanda looking at there's what we call NSOP, the National Surgical Obstetric and Anesthesia Plan. During those studies, we found actually Rwanda can cover, Rwandans can be in the nearest hospital within 2 hours.
That's what I was saying.
Yeah, so within 2 hours. Now, so how are we going to do it? Because now what's happening with the EMS, I think you've seen a lot of ambulances now.
Yes, I've seen the ambulances. There are so many. So, they've almost doubled.
Well, they actually more than doubled.
Oh.
Chigara alone has, it used to have like 4 sites where the ambulances used to be stationed, the SAMU stations.
There's one in Kigali, Muhima, sloping down. I don't know which one.
Now even we have in Kigali city itself, it's got 16 stations. We used to have 4. So can you be worried that in Kigali, with the current situation where we have 16 stations instead of 4, we are not going to be...
Maybe for the sake of the ambulance, maybe I agree. But going back to the study you made of the 2 hours, let's talk to someone who is deep in the village.
Yeah, so the problem now is not going to be in Kigali. The EMS, the Emergency Medical Service System, or we call it actually EMS and trauma, to increase the significance of trauma. Though trauma is part of emergency. So now in Rwanda we have what's called the EMS and trauma, Emergency Medical Services and trauma.
I've seen that.
So we now have a national task force that is working on how to improve that. So it's actually not ATLS, if I can, I didn't want to bring this at this moment, but we can also talk about it.
Okay.
This is as a result, ATLS is a smaller piece of what is in the pipeline. So what has come off, of course,
it's
something
like one piece has just come off.
Yeah, so it started as EMS and trauma. So there are going to be offshoots that are going to come earlier than the others. For example, the EMS, the ambulance, of course, emergencies, how do we handle emergencies? Trauma, asthma, and other things. So we're looking at it in the context of treating a person holistically. So you're going to have pre-hospital. That's where the ambulance comes in. So the pre-hospital has got people that are responsible for handling these patients that they pick from the roadside, they pick from
the scene of accident.
From the scene of accident. Or even from homes, where if it is if it's not trauma. So that's why it's going to be combined. It's combined actually, not going to be combined. So that's pre-hospital. So pre-hospital at the moment is taking a good shape. But what do we still need to do? We still need to train a lot of paramedics to work in those ambulances. Paramedics are people that handle patients before they bring them to the hospital. So that is being worked on. Okay? So those are the people that are going to pick people from the scene of accident. So what they do, they first do the emergency care on scene. Okay.
So the golden hour
That's exactly
is going to be actually the work of paramedics mostly. Is what you saying?
No. Because they are communicating. So that's why the ambulances are spread out countrywide. Okay. So, and again, what's going to happen is that also the hospitals that are ready, because now you cannot have ambulance, a lot of ambulances that are going to take to hospitals, the hospitals that are not ready to receive the patients. So then you have to work on the hospitals. Okay? So the hospitals are also going to be, or are starting to be prepared to receive those people to sort out the issue of the golden hour. Because when they are on scene, they call a doctor in a hospital, in a trauma center. So what we are trying to do is to build a trauma center system. Okay.
Now it's really now I get it. Now I really get it. I just want even people there to get it.
Yeah.
So simply what you're saying is that each hospital will have a trauma center within the hospital where the paramedics who are on the scenes of accidents or where these traumas are happening can immediately call. This 1 hour will not be misused in the transporting the patient. They will do it even within at the scene.
So they start with on the scene. So the doctor tells them, okay, so they describe what they are seeing. So the doctor tells them, now we're going to have different levels anyway. So there are those who can handle what's on the scene based on the what they are seeing there. Because when they call, actually even now in our ambulance system, they call. So we have call centers. The call center will call a hospital, tell them this patient. So the pre-hospital people, those are paramedics, are going to assess. They see the patient. They call a medical director who works with them in the zone, because now we're going to have different zones. So we have different levels of trauma centers with different capacities. Say, for example, you are in the south. So the highest trauma center is going to be CHUB.
CHUB,
yeah. Now, CHUB is going to have district hospitals at different levels. So you see? So you have different levels. Now, depending on the severity of the injury, they take this person from the scene to where the capacity is
to handle this patient.
Is capable of handling this type of injury.
Okay, cool.
You see? So then you don't have to go to a health center, to a district hospital that doesn't have the capacity to another district hospital. We will have a system where a person, they assess on scene, they talk to a doctor somewhere, they describe what they are seeing. This doctor, because now you have a system also that helps these people to describe. So we have one system that describes what they are seeing.
That can tell the severity of the case?
Yeah. So
okay, that's really
this person,
wonderful.
when you're training them, they should be able to follow a systematic way. So that I'll start with, say, this person is breathing like this. So how is his airway? I'm asking. How is he's talking to you? Then you can decide the severity now. Based on just because this patient
those procedures that are
and he's not capable of talking, then there is a systematic way of looking at the way person is talking that tells me his airway is patent. Then I'll go to how he's breathing, then look for bleeding, then look at the level of consciousness. That way, they should be able to quickly communicate to the doctor, and then that is going to help to determine where this patient is going to go based on the severity of the injury. And that is also going to be taken. So the trauma centers are going to be in different regions to reduce the time wasted transferring a person from, say, Rusizi to Kigali. Yeah.
So,
So, for example, each zone, we have worked on it, is still in development, but soon it should be out.
do you
To
have
say,
do you have already established zones now?
yeah, but not yet confirmed. We're still working on it.
Mm.
It's at the ministry level.
Mm.
So the national task force with the ministry,
Mm.
set up by the ministry in a way,
Mm.
is working on those. So that now, if a person gets injured, say for example, is in the north,
Mm.
you should be able to have different levels of in the hospitals, different levels in those hospitals that can handle different severities.
Mm.
The highest going to be, say for example, Rwanda Hospital is going to be equipped to handle majority of cases,
That are
to
in the north.
stabilize the patients, and a very few cases are going to be transferred out to higher levels for treatment. But they should be able to stabilize them, to handle them. So majority are going to be handled there. Very few cases should be transferred onwards
to
higher. But also that because of the capacity, they're going to be able actually to have sorted out the issue of the golden hour, except very few cases.
How long does the training take for someone to be skilled with that skill of taking the trauma case management?
So it's actually not long. It's just knowing being systematic.
Oh, okay.
It's like these courses we did.
So
when we are doing promulgation, so I don't know whether we discussed the promulgation when we were establishing the chapter.
No.
So promulgation was the launch of Rwanda chapter of ATLS. So now we have a chapter. We are among, I think, 6 countries in Africa that have ATLS chapters.
Only 6?
Yeah,
in the whole
very
Africa?
few. Yeah, the whole of Africa.
Okay.
So if you start South Africa has had it since when I went to train. I think they must have started like in 99. Yeah, they got their chapter in 99, I think. Or 98, I think 98. They got their chapter. Then we have Egypt. Then you have Ghana, have Nigeria, next door Kenya, and Ethiopia. So now we are among those.
Oh wow, that's really wonderful. So do we have facts of how this failure to have this has impacted our country or our health sector?
Well, even if you don't have it as such, but we know even worldwide, we know the statistics. So we know that especially in children, trauma is the commonest killer of
children. Yeah. Okay.
Yeah. That's even worldwide.
Why?
Because children do not tolerate those injuries. Because you see what makes children collapse commonly is, we remember the children have their head relative to the body is big. So if they do like this, then they fail to get oxygen. So they die because of hypoxia. It's called hypoxia.
Say that again, because I'm sure I'm not the only one who doesn't know that. Like their head,
commonest cause,
their head,
the head in proportion to the body is bigger in proportion. Like for you and I, the head in proportion to the rest of the body
is normal.
Is small.
It's small.
Yeah. Whereas in children, the younger they are, the bigger is the head.
Let's say 1-year-old kid.
Yeah. So it's almost like if you look at the head, it's almost the same as
the size
rest
of
the body.
Yeah.
So that heaviness and the short neck. Remember, relatively still short. So when they do like this, because being heavy is going to do like this. So it's going to obstruct. And then they're going to fail.
The breathing becomes difficult.
It becomes difficult so they get cardiac arrest. And the commonest cause of cardiac arrest in children is hypoxia.
Okay, cool.
So trauma in children is very bad. And of course, in adults, we know that also the teenagers are very prone to accidents. You see?
Falling down,
Falling down,
getting
sports,
hit by...
very, many dangerous sport things. So they also get injured. And so as a country, if you work on trauma, you reduce a lot of things. One, you reduce the deaths, but two, also the disabilities from, like you find people who they say yabaye ikimuga. But it shouldn't be. If you go to hospital, they align, you are born nicely, it will heal in a short time and you're back to what you're supposed to be doing. But the malalignment or, the crooked legs that you see, they reduce people's activity. They cannot go back to their normal activity, and that reduces
even the
productivity.
Even the perception that they are now ibimuga, as you just said, at times they make someone feel like, I'm not like the way I used to be, so I shouldn't be even acting like I am supposed to,
Yeah, so that reduces your now productivity. So if we can reduce that, if you look at the way we want to organize it, is that so there is the ATLS, okay? When people get injured, so you sort out the pre-hospital, as we had started talking about. So the pre-hospital means before coming to hospital, that means the ambulances, the paramedics. Now that you organize. But together with that, you must organize where they're going to be taking the patients. So that's the hospital. So what are you organizing there? The beds where they're going to be received. How are they going to be received? When they arrive at emergency, quickly, in a very short time, just standing, they'll figure out this one needs serious attention. So they rush you to...
So you're talking about the triage system.
Exactly, so you know it. So you have a triage, or just like this. You're receiving the report from the paramedic or people who have brought the patient. As you receive that information, you're busy scanning, seeing what the patient is.
Putting them in two categories.
So, severely injured, quickly to resuscitation room. These are moderate, so put them somewhere where they can be assessed again properly and they can be investigated. And then those are minor cases, you also have where to put them as they can be able to wait. So you have now separated them into three parts, and you keep them around though to see, because some people can evolve into getting worse. So that should also be kept around. Now, so that's the hospital, and now so that is triage. But together with triage, you should be able, if you find this severely injured patient, you should have an ICU. Yeah? So you should have an ICU bed. If the person is severely injured, they is going to protect their breathing, their airway, and breathing and the saturation and all that. So if it needs to be supported, then they should go to intensive care.
Doctor, let's close our first episode there, and this was our first episode. We are going to close it from there, and then we are coming back. We will come back for another episode.